I'm back. This time, instead of covering the vasculature like I've done in other videos, this time I'm covering the external features of the abdomen, such as the muscles and fascia, and then we're going to get into some high-yield topics for the pelvis. So I know there's a lot going on here, so let's kind of start with the basics here. Here I'm going to direct you to the bottom left of the screen, where you have the different layers of the abdomen, starting with, of course, the skin, and then you have the subcutaneous or fatty layer. This layer is called the Camper's fascia. A way to remember that it's the most superficial layer or fascia is you like to go camping outside, or you have a camp out. And you next to it, just on top of your muscle layers of your abdomen, is going to be your Scarpa's fascia, or you'll camp out and you'll scarpa in, or scarp in. So camp out, scarp in. Scarpa's fascia is going to be significant later on because that is going to be continuous with our Dartos fascia later on in this lesson. Just underneath our Scarpa fascia, underneath the cutaneous layer, is going to be our external oblique muscle. I went ahead and included the external oblique muscle also here so that you can see the way that the muscle striations are going here. Whenever it comes to the abdomen, the muscle layers can be slightly confusing, but the only way to discern them is by knowing the direction of the muscle fibers. For the external oblique, the muscle fibers are going to be coming from a superior lateral direction to a inferior medial direction, like this. The way I remember it is hands in pockets, kind of like this feller, how it has his hands in his pockets, ET for external, and they're coming from an out to inward fashion. Next, underneath our external oblique muscle is our internal oblique muscle. And unlike the external oblique, which has its muscle layers going from an out and in, it's from top to bottom, the internal oblique is rather going to have muscle fibers going from in an out and in fashion, but up facing upwards. And this one you want to do hands on its. Just kind of like how this guy has his hands going from the bottom to the top fashion. So external oblique going down like your hands in your pockets, hands on its going for the IT significant for internal oblique going from the bottom to the top facing upwards. And finally, the third muscle layer that you need to be familiar with is the transversus abdominis, or transverse muscle. This one, as opposed to the external oblique and internal oblique, literally is just going transversely, which is going from left to right or right to left in a longitudinal plane. And then just underneath it, you will have a parietal layer, or parietal peritoneum. So whenever you hear like you have a parietal layer or you have a peritonitis, that's talking about like inflammation of this layer. A significant thing to know about whenever it comes to these things is the Hesselbach's triangle. This significant figure is bordered by the inguinal ligament inferiorly. Then off of your external iliac artery, you will have an inferior epigastric artery, which will come and form the superior border of it. And medially, you'll have the rectus abdominis sheath. This part is very significant because it is below what's called the arcuate line. Above the arcuate line, you have fascia wrapping around your rectus abdominis muscles from each of the different muscles. Specifically, the internal and transversus abdominis muscle have their sheaths going behind the rectus abdominis sheath, lending a stronger support to keep what's inside your gut, like your guts, inside and not outside and herniated. However, on the bottom 1/3 of the rectus abdominis muscle, you have what's called below your arcuate line is where your Hesselbach's triangle will lie. There, you only have the transversus abdominis fascia supporting the backside of the rectus abdominis muscle. Because of only having a single layer protecting what's inside and keeping it from going outside, specifically through this superficial inguinal ring, following the spermatic cord into the scrotum of the male patients, you have a increased risk of possibly herniating your internal organs and having them come to the outside area. And that's where we bring to this figure here, your direct versus indirect hernia. Okay? Direct hernias are, just as the name implies, are going directly to the outside. And the way it does that, as opposed to going to the deep inguinal ring, is going specifically only to the superficial inguinal ring. You will also have people ask you, is it going to be medial or lateral to the inferior epigastric artery? Well, since the superficial inguinal ring is right here and it's medial to the inferior epigastric artery, you would know that the direct hernia is going to be medial to the inferior epigastric artery. And then as opposed to the indirect, which rather than going directly to the outside is going to do it from an indirect fashion. Rather, it is going to be going through the deep inguinal ring and the superficial inguinal ring, following the same path as the spermatic cord to enter into the testes area. So any small intestines has a possible way of herniating through this canal. And this is called an indirect hernia, because rather than going directly into the testicles, it is going indirectly by going through two rings. It can also be said that it is going to be lateral. Your indirect hernia is going to be lateral to your inferior epigastric arteries. And you may be familiar with your inferior epigastric arteries because these will anastomose with your superior epigastric arteries, which you may remember from the thoracic block is a direct branch from your internal thoracic artery. And hopefully you were able to take that brief moment to look up and remember, oh yeah, internal thoracic artery, because that's one of your branches coming directly off of your subclavian artery from thoracic block. So once again, inferior epigastric artery will anastomose with superior epigastric artery, and it will be lying, this artery will be lying directly underneath your rectus abdominis muscle, all the way coming up, and it will anastomose somewhere approximately here with your superior epigastric artery. And just for completion's sake, we have our belly button or our umbilicus right here. And this big vertical line in between your rectus abdominis muscles is your linea alba. Okay, so moving on from hernias, let's get into pelvis a little bit. I went ahead and included this figure because I think it does a great job of summarizing all of the different muscles that you can be found in the superficial space and the deep space of the perineum. Now, you may have heard of the different muscles such as your levator ani at this point, your pelvic floor. These muscles are going to be these muscles that I'll be discussing here are going to be lying superficial or closest to the outside compared to your pelvic floor muscles or your levator ani. I included this figure here because it does a great job of summarizing what fascia and what is contained in each of these layers. So you have three different fascias separating these things, starting superficial to deep. Your superficial of the UG triangle and the uroanal triangle and your anal triangle is going to be your Colles fascia, or the superficial fascia. Okay, so once you get through that fascia, you are now in the superficial perennial space. In here, you're going to have your different muscles seen here, such as your ischiocavernosus, coming from the ischial tuberosity to the pubic symphysis. You are also going to have your bulbospongiosus muscle coming and wrapping around in through the urogenital triangle. And of course, you will have a superficial transverse perennial muscle coming here to attach to the perennial body. The perennial body is a very significant structure because it is the common attachment for many of these muscles throughout your perineum. So it is exceptionally important to know about that as well. And within this, within the superficial space, you have all of your muscles. You also will have your respective erectile tissue. such as your crura, your bulb, and for females, the greater vestibular glands. Okay? These are all contained within the superficial space. When in lab and dissection, may be very difficult to find the erectile tissue because it is just underneath these superficial muscles. They are very thin and very fragile. It's very difficult to find, so if you can't find them in lab, don't beat yourself up over it. It's not a big deal. But just know that they are just deep underneath the muscles. So whenever you're in there looking for it, be very careful when dissecting those muscles respectively. So now that we've covered the superficial perineal space, we need to cut through the inferior fascia, or the perennial membrane, in order to get to the deep perennial structures. The deep perennial structures is very simple with just two muscles. You have your urethrosphincter muscle here, and your deep transverse perennial muscle. It's exceptionally difficult to find the superficial transverse perennial muscle because, as you know, it is very thin, very frail. So most likely, if you see fibers running left to right like this, it's probably going to be your deep transverse perennial muscle. Within this, for males, you will have your bulbourethral or Cowper glands, specifically, obviously, kind of following the male urethral tract. So that's where you can find. So as far as erectile tissue, know that for females in the superficial space, you'll have your great vestibular glands, versus males in the deep space, deep perennial space, you'll have your bulbourethral / Cowper's glands. And then from that point, you would pass another fascial layer going from inferior to superior, or superficial to deep, depending on your orientation, and you will go through the superior fascia of the UG diaphragm. Once you pass this, you will have now entered the official kind of pelvic floor muscles, or your levator ani specifically. Not pictured here is your Puborectalis muscle, which is deep to this, and it wraps around to add tension along with the other levator ani around the anus area. From your Puborectalis, you move on to Pubococcygeus. These muscles from here on out are very simple because they also have a relationship with the coccyx, hence why they have coccygeus at the end of the name. So Puborectalis is basically just a sling that kind of wraps around here, versus your Pubococcygeus will also wrap around the pubic area and will also commonly attach to the coccyx. So Puborectalis, Pubococcygeus, Iliococcygeus, talking in relationship saying it's attaching to the ilium rather than the pubis, and to the coccyx, and then finally is coccygeus. I'm trying to see, here it is. It's very difficult to discern when in lab these different pelvic floor muscles, especially from, instead of like a superficial or external view like this, but from within the pelvic bowl. I would strongly recommend speaking with a lab professor to kind of discern each of the various levator ani muscles. So why is this stuff so important? Because there's so much variability and such minor details. A strong clinical significant reason for this is whenever it comes to episiotomies. This is whenever, say, if you're having a very difficult childbirth, the child is stuck in the birthing canal and can't get out. So rather than risk possibly having a midline, not hemorrhage, but a cut from or trauma from the birthing, the OB physician will rather choose to do an episiotomy, where it's a specific surgical opening to allow for a wider passage for the child to come through. You have the option to do midline or mediolateral episiotomies. The preferred is the mediolateral because we'll get into this a little bit more later on, but you have a ton of nerves and vasculature that will run straight across. If you do a midline episiotomy, you run the risk of cutting some of those nerves and arteries. However, if you do a mediolateral, you reduce the risk of cutting those, and most importantly, remember the perennial body that is a common attachment for many of these perennial muscles. You do not run the risk of accidentally cutting that or causing damage to that, reducing recovery time and improving patient care. So whenever it comes to these, it's preferred to do a mediolateral episiotomy. As a general rule, whenever it comes to innervation, the big mama nerve covering most of this perineum is going to be Pudendal Nerve, which is S2, S3, S4. A good mnemonic for memorizing that is S2, S3, S4, keeps the penis off the floor. Probably a little a little vulgar to remember, but it's a good way to keep it in mind. Off of your pudendal nerve, you'll have different kind of branches coming off of it, going through different areas of the perineum. I'm not going to get into them, but most of them kind of are self-explanatory, such as inferior rectal. You could expect to find it back here. Perennial is coming straight across. That's the one that you want to worry about whenever it comes to episiotomies for sure. And then you have the dorsal nerve of the penis and clitoris and the posterior scrotal / labial nerve. Just like with the pelvic vasculature, you just name it where it wants to go. As far as blood supply goes, the big mama artery that everything's coming through is the inferior gluteal artery, and that one will have your internal pudendal artery. Most likely, it'll probably be internal pudendal, and then you'll have various other kind of branches off of here. The only one I had listed off of here was your inferior rectal artery, and that's just to tie it back to our pelvic vasculature and GI lesson, where the inferior rectal artery will anastomose with the superior rectal artery, causing potential for hemorrhoids buildups. Obviously, your blood from your portal system might be backed up from liver failure, whether the patient be an alcoholic or some other form of liver failure, and cause the blood to aneurysm and herniate and possibly cause hemorrhoids and internal bleeding. So remember that the inferior rectal artery will anastomose with the superior rectal artery, meeting at the pectinate line of the anal canal. All right. And another thing is like your pudendal nerve and inferior gluteal artery, they will enter into the perineum via Alcock's canal, which is the best way to kind of find this is look for your obturator internus muscle inside the pelvic bowl, and that will help lead you directly to these respective nerves and vessels whenever you're trying to learn this in lab. So find your obturator internus, look in the fascia, and that will guide you to your pudendal nerve and inferior gluteal nerve, or inferior gluteal artery, respectively. All right, now this is a very, very difficult topic that gets a lot of people in trouble, or it gives people a hard time, is understanding, because now we have like the abdomen kind of figured out with this figure and these kind of muscles. So how do we get like the layers whenever it comes to the male testes and what they're derived from? So as you may learn in embryo, is that the testicles start originally in the abdominal cavity and then descend down via the gubernaculum ligament. The gubernaculum, which is an awesome name for a ligament, as it's dragging the testicles down into the scrotum, will also take down these different fascia layers as it's going through the inguinal canal out into the scrotum, right? And so as it's dragging these layers, they now will change names. So what was before Scarpa's fascia, right, has now changed names to Dartos's fascia. This is significant because of Dartos's fascia being continuum with it. Say, for example, if you had an infection within the peritoneum or something, because everything's self-contained, the infection could spread potentially from the abdominal cavity into your testicles, which is very unfortunate. Then, as you go through your external abdominal oblique muscle, that will turn into your external spermatic fascia, right? Highlighted with this orange. And this is going through and this is labeled here as your superficial inguinal ring. And then same thing with your internal abdominal oblique muscle. That has now transferred, as far as like the testicles, your cremaster muscles. So if you're a male and it's very cold out, this is responsible for reducing the testicles back into closer to the core body to increase the temperature for the male genitalia. And then of course, you just like going through your external oblique now and your internal oblique, now we have to go through the transversus fascia, giving the internal spermatic fascia, labeled here in blue. And finally, because I remember like the peritoneum, talking about peritonitis, and that's what's inflamed and causing a lot of abdominal pain and discomfort for a patient, that is now called the tunica vaginalis inside the testicles. And this is the one major structure that also goes through the deep ring. Most of these other structures only going through the superficial ring. However, this is the exception, and the Tunica Vaginalis / Perineum is going through the deep or internal ring, inguinal ring. And now this is another big thing that's very important to understand, and for sure significant for boards later on, is understanding the male to female homologs. As you can see, it's probably hard to discern from this picture, but for sure on this, you can kind of see how your, what's the word I'm looking for? Perennial muscles are very similar for females versus male. Here you have like your ischiocavernosus. Here you have your corpora cavernosus. Here you have your bulbospongiosus. And then here you have your bulbospongiosus, or your spongy urethra, or corpus spongiosum. Here you have your bulbospongiosus for the female. I went ahead and converted all of the female homologs over to and the male homologs of each other into a simple chart, so that way it's very straightforward and you understand to know each of the different structures and what the equivalent from one gender is to the other gender. Obviously, the levator ani muscles or your pelvic floor muscles are going to be the same, but I think this is extremely significant to know about. I know this is a very important structure, knowing that the round ligament, which is coming from the uterus through the superficial and deep inguinal ring, obviously females do not have a spermatic cord, but they will rather instead have this ligament or tendon going through it, and that is called the round ligament of the uterus. Rather, the males have a gubernaculum testes. And this is an extremely important picture to know as well, knowing that each of the different structures that will contain each of the different fascia that contain these respective structures. Knowing that you have this superficial or dartos fascia, which is continuous with the scarpa's fascia, remembered from earlier with the abdominal cavity. And then with it, underneath that, you have your deep or bucks fascia. Bucks fascia is oftentimes referenced whenever you have like a straddle injury. Say, for example, you were jumping a fence or had some sort of trauma. This is and then you all of a sudden have kind of leaking of urine within the male genitalia. This is kind of the first thing you want to try and think about is your deep or bucks fascia. Between your deep / bucks fascia and your dartos / superficial fascia, you have your superficial dorsal vein. During excitement or erection, you get the superficial dorsal vein is occluded, and that's what gives you kind of like the structure of the male genitalia. And then just underneath your deep or bucks fascia, you have your nerve, your artery, and your vein. The veins are stacked up on top of each other, and they're kind of, I feel, whenever it comes to lab, the most easy to identify and see. The artery and nerves can be difficult. Just know that your vein is going to be right in the middle, followed subsequently by the artery and your nerve. So your van, just like with the femoral triangle, your V-A-N, V-A-N. And your deep artery is going to be located within your corpus cavernosum, and your urethra, or spongy urethra rather, is going to be contained within your corpus spongiosum. And this kind of white fascial covering is your tunica albuginea. I put this here as a reminder for myself. Whenever it comes, this is an important thing, is that whenever it comes to erections, that is controlled by the parasympathetic innervations, usually the pudendal nerve, S2, S3, S4. Your sympathetic is controlling the ejaculatory part of erectile tissue. So the mnemonic for that is point and shoot. Point being talking about erectile tissue, and shoot talking about ejaculatory function. So P for parasympathetic, S for sympathetic. So I hope that helps for memorizing that. And it looks like that is the end of my slideshow. So if there are any other specific questions regarding the perineum, please feel free to contact me, and I look for and good luck on your exam.